today we're going to talk about removing a standard issue chest tube on a patient from the beginning of the procedure, and also some of the other things that need to be done. So you have a patient with a chest tube who's likely had either an effusion or other problem, a pneumothorax, where the chest cavity needs to be evacuated of fluid and air. And now the problem has resolved itself and the physician has requested that you remove the chest tube. You must and have to have a doctor's order in place and able to remove a chest tube. You can't do it on your own volition. And you have to make sure that the reason that the chest tube is been put in is now resolved. And that usually means a decrease in the drainage coming out of the main tube. Usually there's some sort of confirmation by a series of x-rays that are taken while the chest tube is in situ that shows a gradual resolution of the fluid in the chest. Prior to removing the chest tube, you also need to auscultate the patient's chest and perform a chest assessment. You want to make sure that you're looking at any crackles or wheezes that might be present, any decreased air entry, and certainly doing a palpation around the dressing and surrounding tissue to make sure there's no leak of air, which will be indicated by subcutaneous emphysema. It'll feel like bubbles, or somebody once told me Rice Krispies under the skin. It'll be very, very obvious. If you do feel that, you will absolutely need to mark that area on the patient's chest so that you can mark whether that's increasing or resolving. Once you've done an assessment of the patient's chest, you want to chart that, obviously. You want to take O2 sats to make sure their perfusion is still satisfactory. That way you'll have a baseline for when you take the chest tube out, should that sat change. Part of that will also be making sure that the patient has some pre-education before you pull the chest tube. At this point in time, you're going to talk about the reasons for taking the chest tube out. Your chest tube is now draining less, the doctor has ordered it out, and I will need you to cooperate as part of this procedure, so you will need to go through the breathing exercises with the patient in advance. Generally, we'll coach the patient to take 3 large breaths in and out, and on the third one, big breath in and hold it, hold it, hold it, hold it, hold it, and pull the tube, or hold it and hum out if the patient's unable to sustain that. I think only once have I pulled the chest tube where the patient could not cooperate, and that requires the timing of a circus acrobat. And sometimes that happens. So you really have to look at when the patient's breathing and time your removal. Hopefully you'll never be put in that position, but please be aware that will happen on some patients maybe who are palliative and the chest tube is not going to give them any more benefit. That was the reason that happened to me. So once you've done all this, you're going to have to kit up. So you notice I have clean gloves on. Prior to removing the chest tube, you're going to do a dressing takedown. You'll notice that the dressing has a date on it, and that should be very clear as to when the dressing was last changed. Chest tube dressings are changed 48 hours after first putting them on, and then they're done PRN. But generally, every couple of days you should be taking that down because they can get kind of wet and mucky around the site. It's pretty moist under there. Once all these things have been resolved, you must also make sure that you've completed your SLP and passed it with 80% on chest tube maintenance and removal. That's the theoretical part that you need to have so you can understand the process. Successfully removing a chest tube requires that you be the actual person doing the removal on one occasion, and at least be one of the people that is doing the pinching or the second hand on the chest tube. So you'll need to be the pincher and the puller at least once, complete your SLP, and sign off with your nurse clinician, making sure that you sign your verification of skill form. So, equipment includes a waterproof gown in case there's any splash from the chest tube removal. You'll also need to wear a regulation face mask because this is a sterile procedure. And you'll also need to wear your eye protection in the form of a full face shield. Because there may be some splashing from the removal of the tube, you certainly would not want to get any of that onto your face or in your mouth. So that's advisable as well. Alright, so we go down to the chest tube, and once you remove the dressing, it's usually a Hypofix combination with gauze and a few other ABD pads. Sometimes they're going to be sticky. Now, you can be gentle, but remember that these tubes are often affixed well, they should be, with a suture, which means that you're not going to dislodge the tube, but you want to be careful you don't do too much pulling. It's going to be a little uncomfortable on the ribs. Remembering that this tape sticks much better to a model than an actual human. So you're going to pull down all of this dressing, removing it from the patient. And again, it's not going to be as sticky as this. And we'll cut to the chase here. And there'll be gauze, usually either with a slit in it, almost like a trach sponge. But once you take it down, you'll notice that the chest tube enters the patient's body and has a suture, which is tied in and looped around the chest tube. This is one of the parts that you have to be really careful about examining once you get it cleansed up, and knowing exactly where your suture is entering the skin, and where to cut it close to the skin is to not to drag anything from the surface down and through. So standard state suture removal applies. You want to cut it and drag back through the bottom and up, which is the sterile under the skin portion. Once you've done that, you're going to glove up for your sterile procedure, which involves removing your clean gloves, performing standard hand hygiene, which would be your Purell in this case, and donning your sterile gloves. Make sure that your sterile gloves are in a size that are comfortable for you. And this is a standard dressing tray over here. Please remember that you have to do that aseptically, and you will require a tongue depressor, some extra gauze, and a suture cutter. You're going to use your sterile gloves, and of course you're going to have your mask and your shield on before this. At this point in time, the patient should be comfortable. If you've pre-medicated them for pain, about a half an hour before, this patient should be reasonably nonplussed at this removal. In fact, they'll probably be very happy. So you get your sterile gloves on, make sure you have your arranged tray. I usually use this little splash guard, but a PK would be just as good. If you've just made the bed and cleaned the patient up, you certainly don't want to mess up your area, but have something available here. Your standard dressing tray, you're just going to take your gauze, use your sterile chlorhexidine gluconate and your alcohol combination. This is a tinted one, so you can see where you've cleaned. You can either use your hands if you feel you're really good with them, or you can use your forceps, so you're not going to be around the tube. And of course you're going to scrub and clean any of the exudate around the tube, which there will be, all the way around, maintaining sterility of course, cleaning the tube, cleaning around the suture. You can do this 2 or 3 times again. There's no absolute here, as long as you're being thorough and you're getting a good soaked gauze for the patient. So again, if you want to use your own hands, you can do that, but you want to make sure that, of course, that you're not contaminating yourself and so on. So once the tube is cleaned, this is an opportunity to let the chlorhexidine gluconate dry, and this is where you can have the conversation again with your patient. We've already discussed your breathing pattern, Mr. Smith, so what I want you to do now is we're just going to go over that while I gently remove this suture. So the first thing you want to do is make sure that you're going to take some deep breaths in and out when I tell you, so I'm just going to go through it with you again, so you can use this opportunity to do your teaching. Once you find your suture where it enters the body, you want to slit it close to the skin, as I said, and then if you're removing the suture, you're going to pull it out under the skin and back out the other side. Now, sometimes if I have to get a grip on the tube, I can use the sterile gauze for that, and just find my suture. There it is. Okay, seems to be good. And you'll notice it's going to be wrapped around several times. There. Now remember, when the suture is taken apart, there's one thing that's used to hold the tube in, is not holding in it anymore. So it's really important that you don't let the patient move around. All right. This doesn't want to cooperate the way I wanted it to. And you may be doing this for a while. This causes the most stress, I think, for anybody removing the tube, is to find the suture in the proper place and get rid of it. Believe me, these tweezers in these kits are not exactly the ones you'd use in other things. There we go. Okay. That's a real life situation. Okay, Mr. Jones, we've reviewed how your breathing is going to go, so I'm just about ready to pull the tube. What's going to happen now is we're going to need to have gauze to put on the tube that has a measure of sterile Vaseline. My assistant over here is maintaining the sterility of the Vaseline package. We're going to get enough of it on there and spread it along the gauze dressing so that we can make sure that the entranceway to the chest tube will be well covered with the Vaseline. For some of you beginners, I often tell you to put maybe 2, because if your timing is bad, you end up dragging the tube and half of the Vaseline through. So it's up to you how much you want to use. 1 or 2 should be sufficient. At this point in time, my assistant, who is going to be the pincher in this case, which will probably be the first opportunity you have to remove the chest tube is the pincher, will, with sterile gloves, pinch the opening around the chest tube, making sure that when it's pulled out, she can physically close that while the gauze goes down over. All right, Mr. Smith, we talked about removing your tube, so what we're going to do now is just have you take a nice deep breath in and out. That's good. Have another breath in and out. That's wonderful. Now, the next one, I want you to hold it. Big breath in now. That's great. Hold it, and we're done. Take a deep breath. Beautiful. So if you've coordinated it right, I just want to show you, you actually, no matter how skillful you are going to pick up a little bit of that Vaseline. So as I said, extra is not bad. And one of the things that I didn't talk about when we did this was maintaining suction. If the order for the suction on the chest tube is still on, then you're going to maintain that suction all the way through the removal process. If it's to straight drainage, then you're just going to pull it without suction. If you have a bifurcated or 2 chest tubes to 1 suction unit, which can happen in some other settings, surgery or even in ICU, you would need to have a set of clamps so that you could actually clamp one of the chest tubes, maintaining suction to the first one, pull it, reverse the clamp, clamping the one that's been pulled, and keeping the suction to the second chest tube. That's generally the procedure. Once you've got the gauze and all of the Vaseline dressing on top, you're going to bulk up that dressing because there still may be some drainage from it. I suggest a few ABD pads if you feel it's going to be effluent. Otherwise, a few good chunks of gauze and some Hypafix to keep it in place. Make sure that it's not sticking to the armpit hair. That's often one of the most horrible things, is getting it so close to the armpit that the patient's in discomfort. Once you've done that, you're definitely going to come back and you're going to sign your work. Again, you're going to date it with the date of removal and your initials so the person knows who it is. And this should be clear enough that the next person to come along needs to know it needs to be changed in 2 days from that date. And that is the basic procedure for removing a chest tube. Now, one of the other things that needs to be done post-chest tube removal is to make sure that you do an assessment post, making sure you don't hear any different